Welcome everyone. Um, Welcome to the Greater Manchester Primary Care and Community Nurse Forum for our last for 2022. Thank you for joining us. We really do appreciate you taking this time out of what we know is a particularly busy time of the year. So thanks again for your support. Without further ado, I'm going to head today's packed agenda with an introduction to you and a welcome to our new Chief Nurse, Mandy Philbin. Welcome, Mandy.
Thanks, Leslie, and thank you for having me. Welcome, everybody. At least 50 people on call, that's fantastic. I didn't mention winter pressure because I know you hadn't even got out to it from last winter, so I don't think it's a credit for you all being on call. Hopefully I'll be getting to meet a lot more of you rather than just on a virtual Teams call. But I'd like to thank Leslie, one, for pulling this meeting together, but also opportunity for me to say hello because it's really important. I really recognise the voice of primary care and community can be unheard many times when actually for me you're one of the biggest workforces and the closest contact with patients and their families, and it's really important that we keep on board with what your concerns are, what your pressures are, and actually how we work that through. I've had a really good call this morning with Sarah Brownlaw, who was on the national, she's a community nurse clinical fellow, and she was talking very much around raising the profile of community and practice nursing across Greater Manchester. And obviously there's a big national drive to make sure that happens. So Leslie's always already beyond curve, so that's great. I know pressures that you're facing. It's inundated, particularly with another round of COVID vaccines, and we've got pressure in the system. We can only do this by working together and also at a greater appreciation at everybody's concerns and pressures. So it's fantastic that Leslie's pulled you together in a positive format to be able to take you through, as she mentioned, a busy agenda, but actually an exciting agenda because it's really important areas that matter to you. And I think that's a credit, Leslie. So thank you. If you want me to take any questions, I'm more than welcome to do. And I know we've got 5 minutes. So I'll be guided by you, Leslie, what you want to do.
No, we're fine, Mandy. If there's any questions, we've got 5 minutes.
Lovely. So open to any questions around what my thoughts are. I'd like to hear from yourselves what you think I need to think about, and what you would like to see from your chief nurse. Oh, it looks like I'm going to have a quiet time then, Leslie, if there's no that they want me to do.
Well, that might come later on Monday. Are you staying for the rest of the agenda for us?
No, I've got a rapid review meeting with one of the organisations, with national team that I need to drop on. But I need to find a way to come back into this group to actually understand what we're going to be doing.
That's great. It's really reassuring to have your support. It really is. It's great. And we'll invite you to many more of these Monday, and you can have a section on the agenda for us. That would be fantastic. Thank you so much for coming today. And we'll field any questions that we get through the chat back to you. I'm sure there will be. Yes.
Brilliant. What I'll do is I'll go on to the meeting, but I'll try and keep this team chat open, so I might be able to respond while I'm on other calls, so long as I don't get muddled up in meetings. But that'd be fantastic.
That'd be great. Thanks very much, Mandy. Thank you for coming. Thank you. Bye now. Thank you. Excellent. So shall we move on quickly then, because we have got a packed agenda like Mandy's just said. So first of all, we've got Alfia Ali and Francis Carberry. Is that right, Alfia? Yeah, there we are. Yeah, talking about children and young people's asthma in Greater Manchester. That's great. Thank you, ladies.
Hi everyone, and thank you, Leslie, for inviting us to the forum today. It's a fantastic opportunity for us to use this meeting to talk about asthma in Greater Manchester. So my name's Affia and I'm here today with my manager Fran Carberry, and we are part of the Greater Manchester Strategic Clinical Networks. I have got some slides prepared, so I'm just going to share them on the screen. Bear with me. So I just wanted to take this opportunity to sort of explain who we are when we say the Greater Manchester Strategic Clinical Network. So we are a collection of clinical networks that are led by clinicians, and at the moment we have 8 within the SEN, short for Strategic Clinical Networks. We've a proven track record of leading successful improvements in the region, and we're also part of the Chief Medical Officer team within NHS Greater Manchester Integrated Care. And these are some of the networks. So we've got cardiovascular, stroke and rehab, respiratory, palliative and end-of-life care, maternity, diabetes, and of course, children and young people. So our team, core team, which facilitates the network, we work closely with our clinical leads to ensure that all the initiatives that we are working to are delivered successfully. And these are just some of the support functions that we provide across all of our networks, such as program management, business intelligence, project management, business management, comms, network management, and you'll be able to get a copy of these slides anyway and read through them. So these are just some of the functions that we deliver as part of our core team. Our aim and our vision is for the health and well-being of local people to be comparable with and to be the best in the world. So the 3 aims that we've got here is to improve the quality of services across GM, improve health and well-being outcomes for local people, and also address unwarranted variations in care. And we do this through various means such as development of guidelines, policy, strategy, and pathway changes. And this is all done through providing informed decision making around redesign and service transformation, all based on clinical consensus. And our approach listed here, and these are some of the qualities that make us unique, and we've described them under 4 main categories, such as we are led by clinicians. So each of the network that I described earlier has a clinical lead who works in the local services, and change is embraced and embedded as a result of their leadership. We have expertise, so our core team have years of experience in health and healthcare and social care. They are experts in quality improvement and pathway redesign work. We collaborate with colleagues not just in health but outside of health. So relationships with our internal and external stakeholders are really important to us. So we work with people from across health and social care, local authorities, young people themselves, parent carer forums, and the voluntary sector. And we're also very candid, so we offer independent clinical voice within the health and care system, and we recommend change that will improve the lives of local people, carers, and staff using our honest broker approach. So that's just a little bit about us and what we do at the SEN, and just moving on to what we're here to present, which is around the asthma for children and young people. So nationally, NHS England and NHS Improvement's ambition is to reduce avoidable harm to children and young people with asthma, and overall to improve their quality of life. So they've taken a whole system approach to asthma management, which includes addressing not just health-related issues, but issues such as environmental triggers, providing a comprehensive education programme, promoting more personalised care, and effective preventative medicine, and also an improved accuracy of diagnosis. And they've done this by forming what they've called the National Bundle of Care for Children and Young People. And this is to support local systems with the management of asthma care. Now, the programme itself is a blueprint of evidence-based interventions to help children, young people, families and carers take control and reduce the risk of asthma attacks, and to prevent avoidable harm. The bundle outlines key standards in the care of children and young people with asthma throughout every stage of their patient pathway. I have put a link in the slide here, which will lead directly to the bundle of care and all the documents that allude to it. So please feel free to have a look through that link. The asthma is also part of the NHS long-term plan, as highlighted here. The UK has one of the highest prevalence, emergency admission and death rates of childhood asthma in Europe, despite a slight fall in unplanned admissions. So it is in the long-term plan, and we have in our region, in the Northwest region, there's a Northwest Children's Asthma Group that supports delivery of the asthma bundle of care. So as described earlier on, the bundle of care focuses on improving children and young people with asthma throughout their their life course really. And these are some of the components that are described in the bundle of care. So you've got environmental impacts, early and accurate diagnosis, effective preventative medicine, management of exacerbations and severe asthma. And under each of these components, we have nationally, there are national working groups that are set up under each of the 5 components there, with cross-cutting themes around education and training and data needs as well. And these in the boxes here, there are names of the leads that are leading on the national working groups. I'm not going to go through this in full detail, but this is just a summary of the actions and what we and GM are held responsible for delivering on. So for under each of the components of the patient pathway, such as environmental impacts and all the others that you can see on the left-hand side, we have what we need to do on an ICS basis and what the system action is, who will be held responsible, and what are the actions that we should be responding to. So this slide and the next slide just provides a little bit of a summary to sort of what we're held responsible to and what we need to report into region. So this is some data that we've got from the Office for Health Improvement and Disparities. So we know that health inequalities and asthma are very much linked together. And the Northwest, as you can see from the graph on the left-hand side, were the second most deprived region in England in 2019. There is a significant inequality in asthma admissions by the level of local deprivation. So nationally in 2019-2020, the rate of admissions for patients living in the most deprived areas was 2.4 times higher than those living in the least deprived quintile. And in GM, we can see that the child poverty rates are higher than the national average. And we have wider determinants such as air pollution, low-income families living in poor quality housing, increase in smoking prevalence within the family, and just a basic lack of asthma education, which have all contributed to the increase in hospital admissions and attendance in some of our areas that have very high levels of deprivation. Just looking at asthma admissions by ICS. So these are asthma admissions due to asthma 0 to 19, and we can see that it's persistently higher in Greater Manchester than in any other Northwest ICS and in England overall. So in 2021, hospital admissions due to asthma in the Northwest were the highest in GM, and it's the rate of 133.8 admissions per 100,000. So we're almost twice the national average here. And as you can see from the data there, the hospital admissions were the highest in the ages 5 to 9 and 10 to 14. And this is really just showcasing what we're sort of doing in GM via the SEN. So in Greater Manchester, when the National Asthma Bundle of Care came out, we appointed our Children's Asthma Clinical Advisor, who, as you can see, is Dr. Kalpesh Dixit, and he's a consultant paediatrician based in Salford. Unfortunately, Cal, I don't think, was able to join the meeting today, so we've not got him on the call. But we're happy to link him into anybody that wants to be linked in with Cal.
I've been on the call for the last few minutes.
Sorry, Cal. Sorry, I didn't realise. I didn't see you sneaking, Cal. I'll just stop sharing my screen, and if you could just sort of introduce yourself and just give us a bit of an idea of what your ambitions are in terms of the asthma programme, that would be absolutely fantastic.
Well, I think, thank you, Afia. You have done a sterling job thus far. I don't know who all are on this call, but the key from my perspective and every clinician's perspective, it's not just mine. As clinicians and as carers for children and young people, we want to make sure that children not only control their asthma well, but are taught how to do it. This means that every professional who sees these children has to work in a standardized manner, and that's what we are trying to achieve. Because people live in different areas and there is definite variation in the economic deprivation, there are going to be multiple factors. Patient factors who may not attend appointments or who may not go, but at the same time, depending on where the clinics are held and who runs them, How consistent is the messaging given? How consistent is the follow-up arranged after an attendance? Now we have to remember that these are all preventable admissions, preventable deaths. And we need to start asking ourselves, why has this child had an asthma episode? What can we identify as the cause for that? What can we do about it? And how can we achieve that by educating our children, young families, and their parents in managing in a safe way? And for that, we all have to have consistent messaging. And we know that when you see two orthopedic or 15 neurosurgeons, they will give you 15 different informations. And that's a normal variation. So we need to try and make sure that we all come together as a group and we participate in sharing the same information. At the same time, we are trying to make sure that the pathways for referrals, pathways for assessments, pathways for diagnosis are all robust and standardized, which is what we are working on. Children go to school. School teams are not health related, but they still need to be able to manage asthma in schools. And that's where the improvement in understanding comes from. And I think Irma has written, there is often a lack of understanding about asthma. And that is true. And it also depends upon the perspective of the individual, whether it's a serious condition or not. Because it is so common, it is just taken as a common thing. So we need us as professionals to sing through the same hymn sheet for every child, and every child has to be informed how important it is for their asthma to be controlled and how they can do it. Because you and I are not going to be in their houses. So we have to make sure we do all these things. That's what we are working on. And because there is environmental impact, you and I need to be also talking about indoor and outdoor air quality. You and I need to talk about pollution, how they can help, how they can get reviews, how they can follow an action plan. All these things are a part and parcel of management. So our housing colleagues, our public health colleagues, our education colleagues are all a part of the team. And the people who are bringing this together are the two photos you can see on your screen, aka Afia Ali and Francis Cabri, and the rest of the team who are behind the screens, who make sure that strategically we try to formulate a simplistic way of managing this condition. So I'm always happy to have a chat to anyone on this. And if you want to, you can always reach me via Afia or Fran at any time. I will leave you back to Afia because I need to have my lunch before I start my asthma clinic shortly.
Thanks, Cal. Thank you. And apologies, I didn't see you sneak in there.
Oh, no,
Right.
no, it's fine.
I'll go back to sharing my screen. Bear with me. Okay, so that was an introduction to Cal, our asthma clinical advisor. And alongside Cal, we have recently recruited two more clinical leads to sort of lead on some projects for us. So we have Dr. Claire Murray, who is a professor and consultant in paediatric respiratory medicine at Royal Manchester Children's Hospital. And Jane, who is currently a team leader for the Children's Asthma Service in Manchester. Claire is coming on board to lead on our severe asthma project, and Jane will be leading on our training, education and capabilities project. And both these projects that we've identified align with the national priorities and work streams in developing a severe asthma registry and network and ensuring that there is access to training for CYP asthma for health and non-health professionals. This diagram that you can see on your screen here is the draft Greater Manchester CYP governance. So as you can see, long-term conditions, which has been highlighted, includes asthma. And as one of our work streams, we directly feed into the GM Integrated Children's Delivery and Oversight Group. We are held accountable to them and report into that group, which through the various different levels sort of directly report into the Integrated Care Board. So what are we doing in Greater Manchester? So following the launch of the Bundle of Care, we established the GM Greater Manchester CYP Asthma Network. Now membership for this network includes stakeholders from health and providers, education colleagues, housing, population health, Youth Focus Northwest and the voluntary sector. And as stated before, we appointed our ICS clinical advisor. This year, we've identified some priorities that we're taking ahead for 2022, 23 and beyond. So I'm not going to go into too much details on all of them, but we will be highlighting some of them in the next few slides. So we have implemented the Asthma Friendly School Programme pilot, which will be taken forward by Manchester Local Care Organisation in collaboration with MFT, and they've been appointed to deliver on the pilot over the next 18 months. I will go into a little bit of detail about the Asthma Friendly School pilot in the next slide, so bear with me. Alongside that, we're also developing and adopting the peer mentor network across GM, which will be managed by Youth Focus Northwest, and it will be implemented simultaneously with the Asthma Friendly School pilot. So we know that so through the peer network, mentor network, we'll be training asthma champions within young people themselves, and evidence sort of shows that connections with peers strengthens knowledge, confidence, and enables them to share their stories and experiences of their condition. We have also been part of the GM Asthma app, so it was piloted across Manchester and it's currently going through the evaluation stage at the moment. We are hoping we will be moving on to the level 2 a part of the asthma app at the end of this year and the beginning of the new year in January, which means further integration with the GP systems. Now we will be talking a little bit about that in more detail in the next few slides. As part of our priorities, we are also developing specification for asthma diagnostic hubs with recommendations for adoption by community diagnostic centres. We're also in the process of standardising clinical pathways and standards for CYP with asthma. Through our education, training and capabilities project, we will be looking at all training and education competencies for all people, for everybody that deals with children, young people with asthma, and support them with training and education requirements across all organisations. So not just health, again, schools, social workers, youth workers, etc. We also have a very exciting project set up within housing. So we're looking to standardise an escalation policy for social housing landlords. For example, if we have a family that's living in very poor quality housing, we know at the moment sometimes it's quite difficult to have the housing issue rectified in a timely manner. So we're looking into seeing what we can do in terms of improving access to good quality standard housing, etc. And as part of that, we're also trying to see if we can review the selection criteria for social housing. So we're currently undertaking a mapping exercise to see what the housing criteria is and whether we can include respiratory, which would include asthma within that. And we're also in the process of hoping to develop some smoking and asthma resources specifically designed for children, young people and their families. So these are just some of the priorities that we've identified. The list is very long and exhaustive, but we thought we would focus on a few things that we can concentrate on in the next 6 to 12 months. So as I mentioned before, Asthma Friendly School Project. Now this is an initiative that was initially done back in London, and I want to say it was the Islington CCG. So it was initially done by the Healthy London Partnership, and we had some discussions with them last year in terms of how the project was initiated, what they've learned throughout the project, and what the lessons and you know what were the outcomes from the project. And we had some really fantastic sort of outcomes that came out in terms of standardization, in terms of raising awareness about personalized asthma action plans, and in general just educating our education colleagues when they have a child with asthma. So we thought it would be something that would be beneficial to our GM population. So we funded this through the NHS Children's Transformation Funding, and an expression of interest went out at the beginning of this year. As mentioned, Manchester was successful in the expression of interest, and the overall aim is to improve outcomes for children with chronic asthma and enabling schools to achieve recognition and meet the agreed standards for asthma. I've just taken some data from their presentation that they gave to me a couple of months ago, just to show you some of the data that we have in terms of asthma admissions over the last couple of years and how they've linked that to schools. So as you can see on the right hand side, they've got asthma related A&E attendances, asthma admissions profiles across all schools for the previous 2 years, and it shows the highest figures across schools are collated to a short list of 15 primary schools and 2 secondary schools. The list is to be further refined by education colleagues before the project team invite the schools to participate in the final chosen list. So it's the data there is quite stark, but what they've been able to do with the data here is to sort of identify those schools that they think would benefit from being part of the Asthma Friendly Schools project. And the aim is to include 5 primary school and one secondary school. They will have they've recently recruited to the Band 7 asthma nurse position who will be leading the project with admin support from a Band 4. And the idea is there's some aims and objectives in terms of having a registry of children with asthma, making sure their personalised asthma action plans are available during the school, whilst they're at school, you know, reviewing their inhaler techniques, ensuring that teachers and support staff are aware about the correct inhalers and, you know, how they should be using it, etc. And also for them to be able to be in school and not miss out on those education days, because the school is confident in terms of recognising when a child is in distress or when a child, making sure they're having the medication at the right time, but also having that registry to be able to go back onto to ensure that they've got knowledge of all the children in their schools, in their school that has asthma. So we're really excited to see the evaluation for this pilot. It is currently just in Manchester, but once we get the evaluation and the results from the evaluation, we can the aim is to adopt some of that learning across all of our localities in GM. So very excited for this project, and they've only just recently recruited, so I think we were having an update from them in our next asthma meeting in terms of which schools they've identified. So we're really excited for this to come on board for us. I'm going to hand you over to Fran here, who will talk a little bit about the asthma app.
Hi everyone, I'm Fran Carby, I'm Programme Manager in the children's team at the SCN. Just a little bit of a snapshot of some of the work that we've been doing. Nafi has obviously just been through the Asthma Friendly Schools project, which is a fantastic project. This app here that you can see on your screen is something that was developed in conjunction with Tiny Medical a couple of years ago. There's a long story behind it. It started pre-pandemic. It was supposed to be finished, evaluated within a year, and then of course COVID hit. And in the meantime, we had lots of other changes within the GM system that meant that certain aspects of the app couldn't be developed. We were hoping to have had some interoperability with NHS Care records as well at this point, but that's not happened. So what we have is a standalone asthma app, a perfectly functional asthma app, which is full of really good information, videos, hacks, as they call them. Well, I think I'm an old person, so but this is what the young'uns call it, a hack, when they watch these videos with instructions on and things. So there's a whole raft of information. It also has alerts for pollen, for air quality, lots and lots of stuff on there. There isn't a facility to connect with the NHS login or care record at the moment in this version of the app. But what can happen is that the clinician, the practitioner who develops a care plan with the young person can email or text it or whatever to them, and they can upload it to the app, so they've got the handheld personalised asthma action plan with them in the app. As I say, it should have been done and dusted in a year until COVID hit, so it's been a very kind of long and iterative process developing it and updating it to get it to the stage that it's at now. It's available in the NHS App Store, but also in your kind of Apple apps and your Android ones as well. You'll be able to find it there. So just look out for the Digital Health Passport. Free to use. It's currently available or aimed at 14+ years, and that was purely because of information governance. The good news is that we're working with Tiny Medical, who've been recently commissioned by NHSE to roll out a next version of the app nationally. So the next iteration of this app will have that interoperability that we wanted to have in the first place. It will be connected to care records. So when an asthma action plan is developed, it will automatically upload to the young person's app. And it also will have a function for parents and carers to use. So it can be used for younger children, which again is good news, because obviously that younger age group are the children who tend to exacerbate and have tendencies and admissions that could have been avoided. Are you going to show a snippet of the video, Afia?
Yeah. Just bear with me. I've made a little bit of a boo-boo, so I just need to go back and unshare.
Yep. Afia's going to take you through to a video that Tiny Medical have produced about the app.
It's quite a long video. It was done for the Ask About Asthma awareness that was held a couple of weeks ago. So I'm not going to go through the whole video, just the first couple of minutes, just so you get a bit of a flavour and feel as to what the app can offer to children, young people and also professionals.
Hi everyone, welcome to today's Ask About Asthma video. My name is Dr. Greg Birch. I'm an A&E doctor by background and clinical director at Tiny Medical Apps. We're the developers of the Digital Health Passport. So what is the Digital Health Passport and who's it for? Digital Health Passport is a self-management app designed for young people, anyone aged from 13 onwards. It's also available for parents and carers, for anyone from 5 years upwards. It's been co-designed with young people, with asthma nurses, with GPs, asthma specialists over the last 5 years, really to empower young people to take better control of their health. What we're trying to do is make some elements of asthma care smarter, the elements which are patient-facing, and we're doing that with a mobile app. What I'm going to do is talk you through some of the features and benefits of the app, how it aligns up with the asthma bundle of care for children and young people, some features around air quality as well as around asthma, and how you can get started with the app in your area. The Digital Health Passport is a self-management app aimed at young people, anyone from 13 years onwards. It's been co-designed with young people, with asthma nurses, with asthma specialists, over the last 5 years, designed to empower young people to take better control of their health. And now it's also available for parents, for anyone from the ages 5 years upwards. The key features are around home for care plans and symptom tracking. But really what we're trying to do is make every element of the asthma care, which is patient facing, that little bit smarter. And I'm going to talk you through how we're doing that. And I'd also like to show how the Digital Health Passport aligns with elements of the asthma bundle. Digital Health Passport has got a very high rating from ORCA, the independent body which looks at apps across the UK. And there's some funding from the Digital Health Partnership Award, which means your ICS can implement the
I'm just going to stop it there. It is the link is there will be in the presentation, so please feel free to access it and watch the whole video, which is really useful. But that just gives you a bit of an idea as to the aims and objectives of the actual app itself. We're really excited to go on to the level 2 funding because not only will it have that interoperability with the NHS login, but patients will also be able to keep track of their inhalers in terms of their prescription. So they'll be able to order sort of repeat prescriptions through the app as well. So there's some very exciting projects that are unfolding in the next 3 to 6 months for us, and it's really busy with the asthma programme itself. Just moving on to the final part of our presentation, I just wanted to discuss the national work around the capability framework for care of CYP with asthma. Again, there's links in here which will directly lead to this document, and also the platform where the training has been developed for not health and non-health professionals. So this framework has been developed to allow individuals, employers and ICSs to be aware of the skills and knowledge that are required to ensure that they can safely care for a child or young person with asthma. And as mentioned, it's aimed at both health and non-health care professionals across all aspects of a child's life, including childcare providers, education providers, uniform services, sports coaches, social services and healthcare workers. So who is this framework for? As I mentioned, it's aimed at both health and non-health care professionals, and it's divided into 5 tiers, which each tier describes a level of care a person may be expected to deliver to a child or young person with asthma. So the more involved the care is, the higher level of tier. Now, each of the tiers aren't profession specific, but they describe a level of asthma care an individual may deliver to a child or young person. So each individual should look at their own role and choose the tier most appropriate to the care that they deliver. At each of the tiers, there is a set of 10 asthma capabilities, and each comes with an agreed set of learning outcomes, which is relevant. And the capabilities outline the minimum knowledge and skills any individual must possess to safely carry out their role. So it's assumed that all healthcare professionals undertaking the training will already have some sort of appropriate training and skills that are relevant in the care of children and young people with asthma. So these courses are to provide additional training specifically relating to asthma, and they should sit along any appropriate frameworks that are already in existence. Individuals working at tiers 4 and 5 may choose to complete a portfolio of evidence instead, and these training programs are intended to supplement existing professional training that is already out there in terms of asthma for children and young people. As described here, I think the writing's a little bit small, but as I said again, the slides will be shared. This gives a flavour as to what level of care each tier is alluding to, the example professions and the knowledge and skills each tier has. So for example, tier 1 is purely for signposting, and the types of professions that would sort of access this training would be staff from social care, education, childcare providers, GP receptionists, healthcare assistants, and it'll provide a basic awareness of asthma, its management, things like inhaler use and basic risk factors, and they'll be able to use this training to signpost families to resources, etc. So this just gives you an indication of what each tier enables. All this that you can see here is provided through the link, and the training capability framework is hosted on the Education for Health Care platform, and as professionals or whether you're health or non-health related, you'll be able to create an account to be able to access the training on the website. If you have any issues, please get in contact with me and I'm more than happy to help you through that. And the last part of the presentation, we've got some Mentimeter questions ready, just about 8 or 9, and we just wanted some feedback from yourselves, you know, as professionals dealing with children with with asthma. So if you could all just get your phones out and type in that code whilst I get the questions ready, that would be really appreciated. Thank you. Bear with me.
While Safi is doing that, for those who haven't used menti.com before, you can type in the web address, the menti.com address, and then the code that was on the screen just then. I'll read it out to you. I'll put it in the chat. Actually, I'll just copy it. It will ask you for a code. So if you just add that code, you'll be able to get the questions as Afia brings them up on screen. They should appear in your phone as well. Oh, let me copy it. 8379 8725. Pop that in the chat there.
Thanks, Fran. I'll just let everybody log on whilst I get to the page.
Let us know if you're having any issues. Oh, there we go. You can do it on your laptops as well. You click on that link.
Just share my screen so we can share some of the answers. There's loads of answers all there, so thank you very much. So the first question is, who do you feel is responsible for improving asthma outcomes? And I can see plenty of feedback there, so I'll just give it another minute or so in case people haven't managed to log on.
The bigger words are the ones where people have said that same answer a number of times, so the smaller words haven't been mentioned as often.
Yeah.
See, we've had 31 responses down at the bottom as well.
Brilliant. Just give it the last 30 seconds, just conscious of time. We'll move on to the next question. So what challenges do primary care colleagues face in improving asthma care for CYP? This is free text, so put in as many answers as you want. Give that a minute.
Am I right in thinking the app gives reminders as well, doesn't it, for appointments? Yeah.
And it also gives alerts for pollen and things like that. So
yeah.
if they've got allergies. I don't think the screen is big enough for all the answers that are coming through.
Can you scroll?
Let's see. Yeah. It looks
That's
like,
interesting.
yeah,
It'd be good to know how many rates of DNAs for appointments, because a few people have put that, haven't they?
compliance, yeah.
Mm-hmm.
Right, move on to the next question. What opportunities are there for primary care colleagues within the new ICS in improving asthma outcomes for children and young people?
Can every contact count? I guess just to expand upon that, the integrated care system is previously what we had was a partnership, the Greater Manchester Health and Social Care Partnership. So we've had a kind of an integrated care system for quite a number of years, since 2016 in Greater Manchester. But on the 1st of July, that kind of partnership was legislated, and we've now got mandatory functions within what we call an integrated care board, and all of the previous partners within that not quite informal partnership, they're all now part of one NHS Greater Manchester. So we're working towards more integrated ways of working. When we talk about integration, we talk about horizontal and vertical integration. So horizontal could mean across other organisations, across education, social care. Vertical could mean through primary, secondary, tertiary care.
There's a lot of commonality in these answers in terms of training and education. That's really something that we've previously had, haven't we, Fran, when we've done a questionnaire as well?
Yeah.
Going on to the next question. So which role is involved in undertaking asthma reviews for CYP at your practice?
Nice.
Thank you very much for that. And we just wanted to ask, which asthma action plans are you using? That's interesting. Give it a couple more seconds. Okay, thank you. In the past 12 months, have you undertaken any asthma awareness training for CYP? And if you have, please could you name that training? That's really interesting as well.
I want to know who Tracy Kirk is.
She's famous. Just give it a few more seconds. Okay, to the next question. If training was available, how would you like to access this? So we've just given you some options there. So online, virtual, face-to-face, workshops, a one-to-one or other. Brilliant, that's fantastic. So if anybody, I don't think anybody's put other, have they? No, we'll skip this slide. Do you have an agreed pathway of means of communication between primary and secondary care for your CYP asthma patients? Let's give it a couple more seconds. And on the back of this question, if yes, are you able to share that with us? So the four respondents that said yes to, no. If that one person can get in touch with us, I will put my details in the chat. Please do so. Thank you. And what actions could be shared across GM to support PCNs, primary care in the delivery of asthma care for children and young people? I think this is the last question. I think it's been a recurrent theme, hasn't it, Fran? Access to training, that seems to be one key factor that sort of pops out every time we ask questions around asthma, don't we?
Yeah, as part of the work that that will be done as part of the training competencies work, we'll be mapping against that framework, because we know there's a lot of existing training aside from the Health Education England stuff. So we'll be mapping it against that national framework that's recently been published to see how it fits in.
Yeah, I'd advise everybody to access the link that's on the slides in terms of the training capabilities framework, and have a look to see which tier is suitable for your role. Nationally, they will be auditing in terms of who is accessing it in which area. So we've been told in a couple of months, or I think 3 to 6 months, that data will be shared across all the ICS nationally across the patch to see which areas have been accessing the training. And as mentioned before, that it's not a standalone training, that is training to complement any other training that you've had in relation to children and young people with asthma. And this is the last question. Would you like to be involved in our GM asthma network? That's really fantastic to see. Thank you.
I think we would have been surprised if we ever got a no answer to that question. The very fact that people have joined in for this means a lot.
Yes.
Because they are motivated.
Yes, and I suppose just to, on the end of that question, we have got sort of stakeholders from a lot of organisations across GM, and one area where we're desperately in need to have some engagement and involvement is within primary care. And that was the sort of reasoning behind me contacting Leslie back in August to talk about our programme, our asthma programme, and also to see if we can drum up some engagement within primary care, whether that's from yourselves as nurses in community and practice nursing, or whether you have a GP or colleagues at your practice that may be interested in being part of our asthma network. So if you are interested and you want to be part of our network, please just email me. As I said, I'll put my detail on there, and I'm more than happy for yourselves to come and be part of our network and to participate in all the projects that we're sort of that we've alluded to in the presentation. But we also have a very exciting project within primary care that we want to develop. I've not put everything to do with that on the slides, so I'm more than happy to email send that to Leslie for Leslie to sort of distribute through Claire if that's possible. But a big part of the bundle of care is aimed within primary care, such as early and accurate diagnosis, managing exacerbations and preventative medicine. And this project solely focuses on those three components, and also it links into education and training and also the severe asthma project that we've got. So if anybody is interested in expressing an interest for this project to lead it for the next 12 months, please get in touch if you want some further details. I will send that out to Leslie for Leslie to circulate amongst colleagues on the call. And if you want to circulate to anybody else, please feel free to do so. But we're really excited to have this project and for somebody to lead on it, because there's so much work that can be done within primary care. And as we already have 2 other clinical leads established, it's working collaboratively with everybody, and Cal sort of having that oversight across all of the project leads. So like I said, if anybody's interested, please do get in touch. If you have any questions, I'm available at the end of the call, telephone call or an email. I'm happy to put in a Teams call as well to discuss further. That's the end of our presentation. I'm really sorry, Leslie, we've run over time there, but it's been really wonderful to get some feedback. Do we have any questions? If anybody has any questions,
we can ask for questions if they're there. Just to say thank you so much. It was a fantastic presentation. Some alarming statistics there for us all, and I hope you can see the passion that nurses out there in general practice and the community have for asthma and for children's asthma. We do have a passion for it, and I'm sure you'll have a lot coming forward to support you with this, a lot of interest.
That's what we want.
Training and education, this is what we want. We want standardization. We want to know we're doing the right thing. We want everybody, to know about asthma, and we'd be more than happy for you to come back and tell us how this is going on, and what the results are. It's all our interest. It really is. I'm sure you can see that. Yeah,
we've got some fantastic data from the Mentimeter come back, so that's something that we'll be focusing on in the next couple of weeks. But yeah, as I said, we're here as a team. It's a small team, but we're here, and we're doing our level best to sort of push the program forward. And it's just that participation that we need. So we have secondary care colleagues, we've got housing colleagues, we've got education colleagues, but to get our overall picture, it's really important to have primary care engagement, and that's something that we really want to factor into our programme plan, etc. So if there's anybody on the call that's interested or wants to have a further discussion, as I said, please do get in touch. Whether it's myself, Fran, or Cal, one of us will get back to you.
I'm sure you will. Yeah,
we've had some GP colleagues, I think, in the centre as well, and I think it is really good. One of the things that we need to do is, yes, asthma is a medical model, but at the end of the day, it is how it affects the child. If we can highlight that to the child, asking them how it affects your life and how taking medications will change it, that's a good chance of success, which we use in our day-to-day life. So it is really important, and thank you all for coming. I do have to leave because I'm starting my clinic in the next 30 seconds. So thank you. And it was a pleasure. And thanks, Afia. You did a sterling job.
Thank you. And I'll put
Yeah.
my details on the chat. I'm going to have to leave as well. So if there's any questions, please do get in touch either via Leslie or myself directly. Thank you everybody for all your participation and listening to me waffling on.
No, you were very good. Thank you.
Have a fantastic forum.
See you.
Thank you very
Take care.
much. Thank you
Bye-bye.
both very much. Yeah, thanks. Bye-bye. Fantastic, that presentation. So let's move on quickly. We're a bit late, but I'll introduce you to Sarah. Sarah Tomlinson, are you there, Sarah? Sarah's going to take us through some learning disability update. Hi, Sarah. Thank you.
Hi, Leslie. So can people see that? If you could, I've only got one screen, so if somebody just can say yes.
Yes, we can. Thank you.
Yeah, great, thanks. So just shout out if any questions. Apologies from Jenny, who was going to do this section, and I think she's planned to attend the next meeting. So just to recap, so LEDA, it's been around since 2017 and it's an NHS England quality improvement programme, and the main aim is to reduce those health inequalities and the premature deaths of people with a learning disability. And it's building on research and previous programmes that have been around for considerable number of years. And what LEDA requires, it requires a review after somebody has died, and it looks at their life and death, specifically around what care, health and social care they've received, and it's looking for good practice and also areas of learning. So it's looking about the right care provided with the right support at the right time in the right place, with the idea that the learning from each review drives local and national change. So LEDA is in place across England, not Scotland or Wales. But it's been around for some time, and it links into all the wider learning from death work, and with the medical examiner systems that are rolling out from acute hospitals into community. So it's not a statutory process still, but it is required under either quality improvement initiatives, learning for services, and contractual requirements as well. So just a quick brief rundown of the latest national annual report, and what this is showing is that that we're still getting the reoccurring continuing themes, sadly. So despite it being there since 2017 and building on previous work, people with a learning disability are twice as likely to die from a preventable illness than the general population. Specifically, this specific racial inequalities. So people with a learning disability from Black and Asian communities, they have more avoidable deaths and die early than white people with a learning disability. And sadly, we're still seeing a disproportionate effect from the COVID-19 pandemic. In the sense of twice as many people with a learning disability die compared to the general population. But what we are seeing is real progress in some ways with the impact of people being vaccinated. So for people with a learning disability, when they do get COVID, they're 9 times more likely to die if they haven't had the vaccination. So that's come out in the past 12 months. That's really stark information. So just a couple of brief slides from the national report. So this is just summarising. So this is the issue of the key themes around the health inequalities and the premature death of people with a learning disability. And sadly, what the national report is showing is that 50% of people die. So it's nearly half compared to under a quarter of the general population from preventable illness. There's the map. I haven't got any figures, I'm afraid, at the moment to break down into Greater Manchester, but the death rate, as you can see, is higher in the northwest for avoidable deaths. And we've got the avoidable deaths for respiratory conditions diabetes, hypertension and cancer. Again, that's the national picture. And the next slide is just to summarise those headlines around COVID. So it's still the leading cause of death of people with a learning disability. It was in 2020, it is again in 2021. And in the bottom left, you can see, but there is now a really stark difference. So people, yes, will still contract COVID-19, but if they've been vaccinated, you know, they're 9 times more likely to live than they've not been vaccinated, which is really stark. But sadly, the excess death rate for people with a learning disability is twice as high from COVID than the general population from COVID. So what this, I just want to briefly cover is what this, some of the changes. So linked in some ways to the reoccurring themes that the LEDA programme is still seeing. A policy came out last year. It's the first time we've had an actual national LEDA policy. And that was about, really, it's a sea change, is trying to say, it's looking about, we need to tackle these reoccurring themes. So there's been very much a focus on getting the reviews done. There's a KPI about completing them, and that's still there, but there's a real now formal shift and areas being held accountable for reducing those, the reoccurring themes. So that links with the Health and Care Act, which last year, for this year, sorry, which brought about what we're touching on in the previous presentation about. So in Greater Manchester, we've had the Greater Manchester Health and Social Care Partnership for a while, which other places around the country haven't. But then from the 1st of July, everybody was required to work as a system. So that's now got that legal standing. So we've had a lot of practice in GM, but it's now kind of shifted and everybody across the country now has to work as a system. And that's very much linking the two. So the LEDA policy saying, you know, we can't keep doing the same things because we're not making a difference. We've got to do something differently. And it's about trying to join up, everybody working together to achieve, you know, reducing the number of preventable deaths and tackling the health inequalities to it if we're going to achieve the change. The Oliver McGowan, you might hear that that's got 2 arms to this really. One was around what the actual LEDA review found, which is around linked to the kind of stamp programme about antipsychotic medication. It was also linked to general understanding and awareness of learners' disability, the training needs, diagnostic overshadowing. So some of it was around, and that's kind of picked up in the LEDA policy, but it was also specifically around that new requirement on all providers, and on practices, hospitals, you know, care homes, supported living providers, any registered, you know, your local community pharmacy, to have an understanding of autism as well now. So both autism and learning disability are covered by the mandatory training. So that was introduced from the 1st of July. The actual training itself, the Oliver McGowan, that's still being developed. The code of practice is out for consultation still. So what we're all required to do is meet the existing requirement, which is similar to kind of the previous slide in the sense of what the expectation is for the care you provide, the required competencies. And that's covered by the skills for care. There's that competence framework is there. So when you're incensed expectation in general practice, what awareness and knowledge you should have as practitioners in primary care, it's to you, that's, if you were inspected, that's what the CQC inspector would be asking you about. And your expectation is that current one around the skills for care, that core skills framework, which I can provide afterwards a link if anybody's interested. And the third kind of key driver for why there's been a bit, trying to do a bit of a shift and a system change around LEDA and learning disability and autism is there was also the refresh strategy around autism, young people and adults that's come out, and that's brought together previous policies that were specific for children and young people or adults is now all joined together. And in some ways that's coming behind what LEDA has been trying to do for people with learning disabilities. It's now trying to also shine a spotlight on people with autism, because what the research is showing is that there's similar health and care inequalities that an autistic person has, that a person with a learning disability has. And that's at very early stages, but there's that expectation about improving awareness of autism, understanding it, and having that right support there. So just to move on. So just to recap, so what if you have the things that have stayed the same for LEDA is the basic principles. So after a death, it should be notified. Anybody can notify the death to the national team. It's not a statutory duty, so it's built into kind of services contractual requirements of kind of acute hospital if somebody dies in hospital, etc. So we don't get to know about all of them, but what it triggers is a local review. So the notification goes into the national team, they send it back out to the local team. So it's a local review of the care that person's had, and it's looking at key episodes. So you've got that obviously general awareness of what happened from somebody, you know, diagnosis, etc., from possibly from birth, but it's looking back over the kind of the last 5 to 10 years for significant episodes where of either ill health or diagnosis or treatment. Excuse me. It still keeps the family focused. They're absolutely critical. They're a key part of a LEDA review, and obviously for the families, they're grieving, so it can be very difficult. We have a 6-month window to do the review, so it's trying to judge and invite their family to participate and how they want to do that. The review is everybody still has an initial review, and that looks at the family and one set of clinical care records as minimum, and usually that will be the GP records. So if somebody's lived with a care provider, then the reviewer may choose to look at their records, but usually the kind of the default is the GP practice. So that's kind of the contact in sense of having those discussions with the practice. A focus review is just means a more in-depth review. So your expectation is to you know, to have an MDT meeting with families as well, usually, and you're looking at the more complex cases. At the minute, because autism, say, has just been introduced to the LEDA programme, anybody, an adult with autism, that's automatically a focus review. And again, because of the continuing disparity and the health inequalities by people from Black and Asian communities, that's automatically a focus review to try and uncover more of the learning. It's still, if there's another, because it's a review and it's absolutely not an investigation. So if there's a safeguarding or coronial process ongoing, the LEDA is kind of notified and then just put on hold until they're finished. So often, you know, we often wait for the coroner to decide if there's going to be an inquest, etc. Sometimes the LEDA review will start and the coroner will ask to see the LEDA review, but part of doing the LEDA review is that we need the cause of death. So it's sometimes running parallel, but the principle is the LEDA review goes on hold. And what's still the same is that LEDA reviews cover anybody with a learning disability aged 4 years and upwards. It used to be, when it first was introduced, a top age limit of 75 years. That was removed, but there's still a bottom age limit. But because of the child death overview process, anybody aged 17 and under to 4 years, their death actually goes under the child death overview process, and the LEDA ends up just being an admin thing, sense of click the box, and we just wait for that to happen. There is a lot of work trying to join those two together, but in the sense of common sense, it just goes down the child death overview panel process. So what has changed is mentioned autism. So, and this is for adults with autism, so 18 upwards, and you have to have a formal diagnosis of autism. So there has to be some clinical record. The actual phraseology and the diagnostic codes can be different, but there needs to be a formal diagnosis. And that's for deaths from for somebody who's died from the 1st of January onwards. So it doesn't matter when the notification's made, there's not a time limit, but the death has to have been from the 1st of January. So as mentioned, is this focus on trying to reduce the reoccurring theme. So what's been happening since 2017 is this industry of doing the LEDA reviews, but it's the same learning, it's identifying, and there's local changes with services, with practices, you know, really good work. But overall, the general pattern is still the same themes. We're not making enough of a difference. The other key change is so LEDA was sat within individual CCGs. So you usually have one reviewer who worked for Stockport, or one reviewer who worked for Trafford or Bury, and they would have the reviews for that area, and they would come out and visit the practices and do the work. Because of those national changes where CCGs have finished and we're now all moved to Greater Manchester Integrated Care System and Integrated Care Board, so LEDA's shifted as well. So the two have just kind of gone in tandem, with the LEDA policy saying you've all got to work better as a system because you're not making enough of a difference, to nationally everybody's got to work as a system now. We're not, you know, to make a difference with health and social care. So you shouldn't feel any different. So if somebody was saying, I've got a LEDA review for Joe Blogg, sadly, who died from your practice, it'll still be a reviewer who's got a learning disability clinical background who'll come out to the practice. They just happen to maybe not know anymore about your local area. So so they might, so if they're coming to Bury, where I still work 2 days a week, you know, they wouldn't know anything about Bury systems or possibly Bury hospitals, because it's a GMY team that's now employed by the Integrated Care Board, and it's actually for us, just because of how it's worked out for money and staff numbers, it's actually a joint with Cheshire and Merseyside. So we have one large LEDA reviewer team made up, and they cover all of the area. But obviously it makes sense for people who've got an understanding of Greater Manchester to do those ones from Greater Manchester. But you'll certainly have reviewers who, sorry, excuse me, who might not know Stockport systems, Wigan, Oldham, etc., even because they might have come from another part of Greater Manchester. There's still grading of reviews. So what used to happen is that a review will get graded for quality and will get scored, and that obviously flags up kind of alarm bells for different scoring. That's still happening. So the overall quality the person's had, not just one episode, is looking at, you're making a judgment kind of over their recent life. There's now a new score as well, a second score about the availability and effectiveness of services. And that's looking about basically how everybody works together. So from the practice to the community teams, to the adult social care, to the care home, to the supported living provider, did those three services work well together in looking after this person with a learning disability, or this person with an autism, or an autistic person. And the other just change is it's just to let you know, when LEDA is still the right word to use. Some people say leader, some people say LEDA, but it's still the right term. The change was, it used to be formerly called the Learning Disability Mortality Review Programme, and now to recognise it with a lot more input from people with lived experience, is shifted, and it's learning from the lives and deaths of people with learning disability, autistic people. But again, it's still just referred to as LEDA. And so I just realised I've not really clarified. So previously, up until the 1st of January, LEDA, to be eligible for a LEDA review, you had a learning disability and or autism. So people with autism were previously reviewed, but they had to have a learning disability as well. From the 1st of January, people who've got autism only can now be reviewed with no learning disability. So it's a very different population kind of client and group. So the key things that are still showing about why, you know, we've got to try and do something differently. It's consistently since 2017. It's the key thing to make a difference around annual health checks, and then also having a health action plan from that. And that's why there's a lot of focus around having the accuracy of the LD registers, in the sense for trying to capture the right, you know, all the people who are eligible. So even if you have a child who's got a learning disability diagnosis and isn't going to hit the trigger for an annual health check till they're 14, it's for people just getting them on the register. So having those registers as accurate and as full, because there's a lot of underrepresentation. So it triggers the annual health check. And there's been some research by user groups this year where you know, there's people and carers saying they've not even realised they've had an annual health check, you know, so, or had a health action plan. So, but what the consistent positive practice, if people have an annual health check, that opportunity to check in, identify any early illness, etc., just maintain people's health is absolutely vital, and doing those well. Vaccinations, so pneumococcal, influenza, and obviously COVID, particularly for people who are transitioned from children to adult services. Again, that's a key area of learning. So people often shouldn't be used to the nasal spray. So again, it's just having that, hopefully that you'd have that community support from specialist services, but being aware that if you've got a person who is, you know, 18, 19, possibly offering the nasal spray for the flu is maybe a way to kind of keep their engagement and to accept the flu vaccination and cancer screening. The next one is just, this is the key, I suppose, the key message about if there are a low number in your practice population list, you know, out of, you know, maybe 9,000 people on the practice list, you know, it might be 30, 40, 50 people. And I think, you know, that's always going to be that tension, difficulty of, you know, and the expectations. You're not a specialist learning disability nurses, you're specialist practice nurses. But please, you know, use the community learning disability teams. There's a resource list at the end. The amount of support differs, but the principle is absolutely there, that, you know, they're there, whether it's a link nurse or however, they should be there to support you, whether it's just picking up the phone call and saying, can I just run this by you? Or actually, no, I need you to support, I need your support, I'm struggling with this family or with this person. And the other key message is around reasonable adjustments. And I think whatever, yes, it's a legal duty under the Equality Act for any service, and that's from hairdressers to hospitals to pharmacies to GP practice, to make reasonable adjustments for anybody with a long-term kind of disability. So it covers people with learning disabilities, as you would do for mental health. So it's there, but I think it's often the things that you do anyway. I think, you know, as a clinician, but I think often it's where we see it falling down is that it's not consistent. So it's, if you weren't there, for example, would it still get done? Or if a particular GP wasn't there, would it still get done? And often it's very, you know, it is the small changes. So it's about having, you know, that double appointment time. And, you know, there's other things about meeting and greeting people and letting people wait in the car rather than waiting in a noisy waiting room where there's a lot of stimulus, the light, the noise, the people, whether you're able to provide a quiet waiting area. So these are all reasonable adjustments. You know, there's nothing kind of complex or fancy about them. Communication needs, again, letter reviews, people still get texts when they can't read the texts. While some people get easy read, and, you know, and there is a few people who find that very, you know, they're very offended by getting an easy read letter. So again, it's about your systems you've got in the practice that would flag up. So if you put my name in, whether it's the reception answering the phone call to me, to booking me appointment, it flags up on the system that, you know, whether it's phone calls or easy read or I can't read texts. And I think just knowing that, because that's, again, consistent learning we're finding with letter reviews. And then just being aware that, you know, it's just having some basic understanding of possibly how to talk with somebody with a learning disability about simplifying speech and about, you know, that 10-second pause rule. So you kind of give some information, wait for somebody to think about and give you a response. What we also find is in some areas of learning around DNA follow-up. So these are vulnerable people, and if there is a DNA, it's about having a system to follow that up. Again, we've seen some really kind of excellent practice over the past kind of couple of years with COVID about, you know, that really considering the flexibility to have for somebody with very complex needs, both physical and mental health and learning disabilities, about, you know, you add them to your housebound list for your practice. And again, it's just giving that, it's a reasonable adjustment that you're legally required to make, but also makes sense in the sense of the expectation for somebody to come into the practice can be really difficult. And again, we've seen some fantastic reasonable adjustments with the mass vaccination sites for COVID, where people, you know, will tell a steward. So it's similar, and then just go. So there's no queuing. You go straight in. You don't have to book in. Again, just points where you're going to just be extremely difficult for somebody without the language, anxiety, or people have stayed in the car and somebody's come out to vaccinate them, or they've been and stayed in the car park or gone into a garden nearby and vaccinated. So it's just giving examples of reasonable adjustments. And I think it's just having a system in the practice where, because again, it's a small number on your practice list, where there's that flagging of a high risk and knowing to do something extra. Another key learning point is around consistency of clinician. What we've seen even pre-COVID and obviously more now is the difficulty of somebody who's very vulnerable with often communication needs, seeing different practitioners, whether it's a GP or practice nurse. But then the reality is your time and capacity to, you know, and what some of the learning practices have done is that they've appointed a second learning disability clinical lead. So it might be a healthcare assistant who's been trained up, and they kind of hold the LD register list in some ways, and they kind of make the contact. They proactively contact people to invite them in for annual health checks, whether you do them over winter, whether you do them on people's birthdays, however you do it as your practice. But somebody kind of has that responsibility and is a point of contact for either the person themselves or their family or the carers to ring in and say, can I speak to Sarah, because I need to kind of organise this, please. And again, it's a reasonable adjustment, but all these things that you're doing are excellent practice. So when CQC come and inspect, the things you do, they're just excellent, and you know it's really good practice. But you know, so the roles and responsibilities are yours to decide at a practice level. But certainly we've seen if there's a second LD clinical lead, and absolutely understand you might not have the capacity at the time for you to pick it up, but whether it's then kind of having maybe say a healthcare assistant who can pick that up. And the other bit is around some of the learning we've seen around consent and decision making. So there's absolutely tools that I can share some more resources later. I wasn't quite sure what people wanted today, but there is resources. So again, who is your second kind of your clinical lead could be doing this work for you. So before somebody comes in, that the healthcare assistant has done that kind of prep work around capacity, etc. So when somebody comes, all that's done. Because the flip side is that sadly, I mean, I think confidence around mental capacity and consent and decision making it's really difficult. I think there's very few clinicians who feel confident about it. The specialists are there in the sense of the community learning disability team to help, but even then, you know, what we're seeing is certainly with families without legal authority being able to make an unwise decision. So we're refusing to have the COVID vaccination, and then the person we then see has then died from COVID. So that the impact is, you can really see the impact there, and that families had no legal authority to make that unwise decision. And what we're seeing is kind of that scrutiny more and more. And I think, you know, and that certainly for that individuals, a recent one I've been involved with, that person had been open to so the GP is the decision maker, and that's the difficulty. So it ends up, the book stops with the GP as the decision maker, but everybody had been involved, from adult social care to the specialist community learning disability team, and this had been a family where there'd been difficulty engaging them. So but they'd kind of left the GP practice to it without enough adequate support. And so so it's just being aware to kind of, I suppose, some of the easy things you can do which make a real difference, some of the red flags, and absolutely contact the community LD team, because, you know, the sense of your skill is being as a practice nurse and that clinician, not as a specialist LD nurse. I think done. Yep, so there's just some resources. So I've just added, and absolutely we can do more different resources if but this is just for the local your local community learning disabilities team. So that's me done. If anybody's got any questions. Thank
you, Sarah. That's great. Another fantastic presentation there. One too good to stop, really, because we have run over time, unfortunately.
Apologies.
We have got some questions in the chat. I don't know whether or not you can answer them and answer those people so that people can see what you've responded to whilst we move on.
Right.
Are
Yep.
we okay to share your presentation with everybody? Because there's so much good stuff in there that, you know, it's just a shame we haven't got the time to discuss it more. But perhaps at another meeting we can go into more depth with that. Maybe you could do a breakout for us, and people who are interested in asking those questions in detail can actually ask you that face to face. But thank you so much for today. That was superb.
Oh, you're
And
very
for
welcome.
stepping in at short notice. It was very good of you. Thank you so much.
You're welcome. I'll answer the thing, and then people can just ring people later for
That
more
would be great.
information.
Yeah, and we'll share the presentation, so they'll all have the contact numbers. Thank you so much, Sarah. So, like I said, everybody, we are a little bit overrunning, so our breakouts might be a little bit shorter than usual. I'm just going to pass you over to Sheni now. Thanks, Sheni.
Thanks, Leslie, and hi everyone. I am going to be running a breakout in a minute, but I've been working with Claire, Leslie and the team to really kind of get a little bit of a sense from a wellbeing perspective where you are up to as our colleagues and our peers. So we're going to do a little bit of Menti. I'm mindful that you did a Menti earlier on, so we'll have a different code. So if you just bear with me 1 second, Claire's going to pop the details into the chat. And hopefully this should be up on your screen now also. So if you can please go to www.menti.com and the code is 57156324. That's 57156324. I'm just double checking that you can see the slides on the screen because I haven't got it up on my screen yet.
We can, thanks, Sheni. Yeah.
Wonderful, no worries. So as you pop in, if you can just kind of click the little heart button so I can see you coming in, that's brilliant. I'll give it a 15 seconds and then we'll move on to the first question. Wonderful. Oh, loving all the hearts today. Tuesday, it's a tough week already, so let's keep it going. Okay, so first question. How are you feeling today? How are you feeling on a day-to-day basis at the moment? So we've got a sliding scale from 1 to 5. The 1 is treading water, 5 is feeling good, and 3 would be about okay, doing okay. So I'll give you a minute or so just to kind of get your scores in. And of course, we asked this question at a previous event. So the network has been running for 2 years now. This is the 8th event. And it gives us a little bit of a barometer to see how people are doing over a period of time. So really welcome kind of your input into this. I'm mindful that we've got about 39 respondees and we've got over 90 people on the call. So I'm hoping that everyone is logged on to the Menti okay. If you haven't found your way in, it's www.menti.com and the code is at the top of the screen or in the chat, which is 57156324. So the majority of people are middling. So kind of doing okay. So not quite treading water and not quite feeling super great either. But that's okay, actually, because it's a really busy time. We can see that shifting a little bit. We've got some more people kind of checking in. That's brilliant. I think that's just about settling in. So I'm going to count that as a 3 because I'm a round up kind of girl. So we'll take that as middling there. Okay. Question 2. Do you feel more or less aware of your individual personal well-being than you were, say, 18 months ago? And are you more aware of what you need to stay well? So we've got another 1 to 5 here. So 1 would be you're not aware of your current well-being or you're not doing anything active about it. And then at the other end of the scale would be 5, which would be you have got more awareness around your well-being and you know what to do to keep yourself well. So again, I'll give you a little bit of time just to get your scores in. And I'm really pleased, actually. Already I can see that there are more people who are responding with a high level of awareness and hopefully a higher level of having a good action plan to keep yourself well in the first place. Fantastic. So 3.7. So again, not quite close enough to round it up to 4, but we'll go with that one. Okay, your chance to give us a little bit of feedback. What is impacting on your well-being at the moment? And by that we mean your physical well-being, your psychological well-being, and your practical well-being as well. So what are the things that are impacting on your well-being at the moment? And you might want to talk about things that are happening in the workplace, or indeed something that's happening outside of work that basically impacts on your ability to be at your best. So we can see lots of feedback coming back here. So practical work overload, finances, overwhelming workload, time to do what's important, university, time poor, short-staffed, stress, time. I'm seeing some themes here, by the way, folks. Work-home balance, finances, uncertainty with work, work-life balance, too much to do, too little time. Really succinctly put there. Physical illness, workload. Patient expectations and what's possible in a current post-COVID world. Absolutely. Nasty patients. Yep, we're all aware of those unfortunate kind of scenarios that as colleagues you're all facing on a regular basis. Physical well-being has been a bit rubbish. Wedding planning stress. Oh my goodness, my heart goes out to you. Work pressures. Not enough hours in the day for work, kids and kids activities. Absolutely. So there's lots of really kind of key themes there. Sad. So I'm going to take that as seasonal affective disorder, I think it stands for, or because it's in capitals, or perhaps you are sad, or feeling sad, sorry. So I'll let you decide what that might mean. So psychological well-being outside of work can impact on my health, absolutely. When we talk about good well-being, we can't just talk about what happens to us in the workplace. We have to talk about our whole selves, so it's really important. Busy work-life commitments, financial constraints, absolutely. Staff issues, conditions, i.e. no pay rise, no sick pay, appointment pressures, rush to do reviews, not active finances. Yeah, so there's some real kind of running themes there. Time, pressure, absolutely. Okay. Let's move on to the next one. I can see they're still coming in. I'm a little bit reluctant to move on, actually. Busy work, family bereavement. That's really tough. And actually, if whoever's put that in would like to access some additional support, we have got the bereavement service in Greater Manchester. It is brilliant. So please don't hesitate to kind of contact them. TATT and can't juggle all the balls. I might be showing my age here. I don't know what TATT stands for. So please help with that. Tired all the time. Oh, I need that one. Yes, thank you for that. Okay, feeling pressure to work additional hours to cover extended access, poor staff retention, having to cover nurses that have left, increased demands from patients. And I've just seen the last one, which I'm going to mention before we move on, rude patients. Okay, lots of key themes there. Do you know where to find the support when you need it? So when we started to have this conversation a little while ago, the Greater Manchester kind of wellbeing provision was still being stood up. We were trying to get the messages out there. We were trying to get people to connect with that provision. I'm hoping that on this 1 to 5 scale, we're going to see a little bit of a shift. So 1 will be that you're not aware of where that support is. And 5 will be you're accessing it, you know where to find it directly yourself. That middling bit would probably be where you might not know how to access something directly, but you know somebody who can help you. So it might be a wellbeing champion, a trusted colleague, or a line manager, or somebody in the workplace. So I can see we've got a little bit more variation here. We've got colleagues who are responding. We're not quite there yet in terms of numbers, so we'll just give people a chance just to feedback. We're kind of middling here, which is not bad. But I think we can probably do better with this one, actually, just to make sure that people are aware of where that support is when you need it, and that you're able to access it discreetly yourself or get the referrals that you might need. Yeah, we've got some more responses, but it still seems to be around that middling end. So we can certainly do a little bit more around that. Wonderful. And then final question before we move into the breakouts. What would help you stay at your best? Is there anything that's helpful to know about? So we've just talked about, and you've fed back about all the things that are impacting on your well-being. What would help you? I'll give you I'll give you a minute or so just to get your feedback in. Okay, so retirement, financial support, winning the lottery, being valued, accessing support, more time to focus on important work issues. We are very isolated, money and time, pay rise, less patience, forum to help keep connected, better support from education facilities, not referrals, better conditions, fair pay, more of a voice like GPs have, treated with access, recruiting more nurses, support from managers, being valued. Again, we're seeing the same things again and again here. Understanding the pressures of the day that nurses face, absolutely. You work part-time for a better work-life balance. I do appreciate this, but it's not possible for everyone. Totally agree. Security at work, working under the Agenda for Change contract in a GP general practice. Better work-life balance, more staff, less isolation. Used to have clinical supervision years ago, was helpful, but there is nothing now. Feel more valued, more staff, standard pay conditions like in secondary care, more holidays, pay rise. NHS nurses get a pay rise, but not GP nurses. Okay, that's really important to kind of create that distinction for people who might not be aware of that. Inclusive, holistic support, good work-life balance, sick pay, recognition of what we do, better pay, then can cut hours. Back to floor for senior management for us to feel understood. Absolutely. Forums. Appropriate time to do appointments, relief pressures, feeling appreciated, pay rise. So again, we've got lots and lots of repeat kind of themes there. What we'll do is we'll pull all of that together. I know that Leslie, Claire and the team do a lot of kind of analysis of all the feedback that you share with us. So I'll leave this last question open in the background, so I'll stop sharing now, but it will remain open. Please do keep putting your feedback into that. It's really helpful to know what's important for you, because actually it helps the team kind of do a little bit of programming moving forward. And on that note, I'll end there because I'm mindful that we need to move swiftly into the breakouts and hand you back over to Leslie. Thank you.